So I've been given the topic by Dr. Kamal that, and he spoke to me that, okay, Abhishek, so you have to cover all these topics. So I'll try to do justice to his faith. And I believe majority of the audience are oncologists basically. So I thought I'll keep it slightly simple and which is slightly different than our radiological audience. So pardon me if my talk is pretty basic, but I thought from a oncological, from a clinician point of view, it is important that we understand how the imaging is proceeded in CA rectum and what are the modalities and what are the advantages and how we look at it basically. So basically talking about the basic anatomy, we know that the rectosigmoid junction usually begins at the S3 level, and from the sigmoid colon, the rectum fits from the sigmoid colon to the anal canal, and it actually lies in the extraperitoneal pelvis, surrounded by perirectal fat, which is actually bounded by the mesorectal fascia. So this is an axial T2-weighted MR image. So if you would see, this is the rectum, that is the urinary bladder in front, and this is the perirectal fat and surrounded by the mesorectal fascia, which is actually a hypo-intense blackish line. So this again figure depicts how the perirectal fat is all around the rectum, except for the peritoneal reflection that comes anteriorly to the upper and the mid part of the rectum. So this sagittal image again shows how basically the rectum is divided from the low, mid and high 1/3 and basically continues from the sigmoid colon to the inorectal angle, and a corresponding sagittal image on a MR showing how the rectum is seen. And this is the bladder, the anterior peritoneal reflection, and beyond this, the sigmoid takes anteriorly, and this is a sigmoid colon. Again, a coronal image. This is important in terms of the sphincter involvement for sphincter preserving surgeries, and a similar corresponding coronal image showing how the external sphincter and the internal sphincter wrap around the rectum, and on MR, this is how we talk about it. I talked about the peritoneal lining. We know that the anterior peritoneal reflection covers it actually comes and towards the anterior surface of the mid rectum, and while we go more up, so it also drapes around laterally to the higher part of the rectum. So this is important from the surgical or treatment point of view. Very big from the very beginning, it will be like the best. If you want to win a cricket match, the best bet is to have a good opening batsman. So I'll throw straight away the structured reporting format that we follow at our hospital. So this is something that as a radiologist we also take help of. That these are the factors, these are the parameters that we need to assess the disease on, and this is how we would follow all such patients. So this is how we talk about distance of the lowest. The lesion from the anal verge, the longitudinal tumor size, the circumferential tumor location, the tumor relationship to the anterior peritoneal reflection, what is the T stage. So for mind you, MRI, on MRI it's very difficult to talk about T1 and T2. We can only talk about T2 versus T3. And when in terms of T3 lesion, what is the maximal extramural depth of tumor invasion depending on the staging, and whether it's a T4 lesion or not. Similarly, talking about mesorectal fascia involvement and anal canal involvement by the tumor in terms of whether it's a partial thickness or a full thickness, internal sphincter involvement, whether it is going into the interspheric fat plane or even beyond into the external sphincter. Talking about in terms of whether the lymph nodes, what are the mesorectal lymph nodes, the size, the margins, the shape, whether there is CRM involvement, whether there are extra mesorectal lymph nodes, and extramural vascular involvement, which is a very important factor in terms of that will determine the prognosis of the patient. In terms of whether the tumor is a mucinous or a non-mucinous one, the T2 weighted imaging is important because the mucinous tumors will be hyperintense. And diffusion restriction is important because that will actually determine the response assessment after neoadjuvant CT-RT. So that was basically a gist of what this talk is going to be. And if you can just go back, so these are the points that a radiologist would actually report, and even these are the points that we even discuss in our tumor boards in terms of how to plan for these patients. We know that endorectal USG is highly accurate for T staging. It is actually more accurate than MRI for T1 and T2 lesions. However, it has a limited field of view. Therefore, the information on CRM or extra mesorectal lymph nodes is not always available and is actually operator dependent as well. CT is a useful modality. However, it is mainly used in the metastatic workup. In comparison to MRI, the MDCT is inadequate for prediction of CRM and has a low accuracy of T staging. And even it is difficult to predict the sphincter status on a CT scan, and anterior peritoneal reflection is not very well visible. PET-CT has got no significant role in the initial staging in rectal cancers in the absence of a synchronous metastasis. It is used for cases with limited resectable liver or lung metastasis to rule out extensive metastasis, or especially where radical surgery like exenteration is being planned. The localizing site of disease recurrence in patients who have a rising serum CE level and non-diagnostic conventional imaging evaluation is another place where PET-CT may have a role. In terms of T staging, we know that the T1 and the T2 staging, T2 staging is up till the muscularis propria, and T3 when it goes beyond into the mesorectal fascia. And depending upon T3A less than 1 millimeter, B is 1 to 5 millimeter, C is more than up to 5 to 15, and D is more than 15 millimeter. So this is how it is seen on the MRI, and this is if you would see the hyperintense tumor. So this is exactly the tumor that is seen, and this is a mesorectal lymph node. I've talked about the T staging in terms of size T3, A2D, and intermediate signal intensity spicules or nodular based broad-based tumor extension is also important, because this is intermediate signal intensity spicule that is actually coming out. And so if you would see, this is a broad-based tumor extension beyond and into the mesorectal fat. T4 includes the involvement of adjacent structures. T4A is the involvement of anterior peritoneal reflection, and T4B is the involvement of other organs. We talk about definite invasion when there is a loss of fat plane or abnormal signal intensity. In this particular case, you would see the tumor actually invading, going beyond the mesorectal fat and almost up to the lateral pelvic wall. In this particular case, it is involving the anterior peritoneal reflection and going beyond it. The nodal assessment, it is important that to talk about the morphology of the lymph nodes, not only the size, but the shape is also important. The malignant suspicious characteristics are when they have indistinct margins, whether they are a heterogeneous lymph node or a round lymph node. And in terms of when the lymph node is beyond 9 millimeter, definitely it's suspicious for malignant node. However, when the nodes are smaller than 9 mm, depending upon the size, we need to have a morphologically suspicious characteristics depending upon what size it is. If it is less than 5 millimeter, it would need to have all the three characteristics, and that would actually improve the suspicion level for the lymph nodes. In terms of restaging after neoadjuvant CT, the nodes with less than 5 millimeter are considered benign, and nodes beyond 5 millimeter are considered malignant. So this is a graph, this is a diagram that shows about what are the common lymph nodes, the mesorectal lymph nodes, and how beyond mesorectal lymph nodes, how the chain is there and how their involvement can happen. In terms of tumor size and location, it is important to talk about the craniocaudal length and the location of the tumor. The circumferential O clock position over here at what clock the lesion is, the relationship to the anterior peritoneal reflection. This relationship is important, and distance from the anorectal junction and the anal verge. So this is how we actually take a measurement. This is the tumor. This is how we measure that this is the extent of the tumor involvement. And this is how we measure the distance, how it goes about it. In terms of tumor appearance, we know that mucinous tumors I talked about, they are T2 hyperintense. So these would be bright on T2 weighted images. So we were taught a cheat code while we were doing our MBBS for MCQs that World War II. So water appears white on T2 images. So whenever we are seeing any MR images, we should look at the urinary bladder. And if the urinary bladder is white, that means it's a T2 weighted image. And similarly, a non-mucinous tumor will not have a high intensity on the T2 weighted images, or it can have an intermediate signal intensity on T2 weighted images. Talking about the circumferential resection margin, it actually forms a basis for the TME, total mesorectal excision, and if it is involved, definitely poor results are seen. So this is actually a best predictor of local recurrence and poor survival. So this is one such patient that actually we can see the tumor actually speculations and going and almost. However, this is beyond 6 mm from the mesorectal fascia. So this is mesorectal fascia not threatened. So only when any tumor extent reaches within 1 millimeter of the mesorectal fascia, that is when we call about the threatened or involvement of mesorectal fascia. Extramural venous invasion is another important thing. and actually that signifies the poor prognostic factor for such patients, and it is basically nothing but tumor invading veins within the mesorectal fat, and it has an important factor that it leads to increased local recurrence and poor survival. However, it has an intermediate signal intensity on tumor within the vein, and generally causes expansion and disruption of the vessel. So in this particular image, you would see how a linear structure is going beyond. So this is actually the vein in which the tumor has expanded and distended it and causing this signal intensity. Another patient, you would see a linear filling defect signal. The normal vessel would have a signal word. In this particular patient, it is lost. So this is the EMVI. Talking about the sphincter complex, we know that it is involved in low rectal cancers, and it is actually useful for involvement of them is useful for planning sphincter sparing surgery. So this is one such patient that you would see how the coronal images help in assessing the sphincter complex on such images. In terms of the MRI protocol, how we do about it. So there are multiple sequences. What is the most important sequence that we should be doing is a high spatial resolution T2 weighted sequence is something that is very important. Planning, I would not go into the radiological details of it, but it should be axial, coronal, and sagittal images. However, if I would have to stress out, then diffusion weighted imaging is something that should always be done even prior to treatment and post treatment, because there would be patients for assessment of whom this would actually come in very handy. And definitely a post contrast T1 3D images are something that is very important because you can actually get a thin sections in these, and in terms of other parameters which I will come on to soon, you would see how it can play an important role in assessment. In terms of primary tumor post-treatment changes, we should know that it has a varying appearance and there are different challenges to interpret it. So apart from the traditional things of the lesion reduction in terms of as per the various evaluation criteria, there are upcoming papers that talk about volumetric measurement of rectal cancer, and they have suggested that this is a slightly better parameter in terms of linear length measurement, and they have said that whenever there is at least 70% reduction in tumor volume after CT-RT, these patients are ones that are associated with improved disease-free survival. However, it is always not straightforward. Edematous submucosa can also appear T2 hyperintense, as in this case, post-RT. So this can actually mask the underlying tumor, or if it was a tumor previously, it can be difficult to assess whether the response has been seen or not. And we know the thickening of the mesorectal fascia circumferentially could be actually due to post-RT fibrosis. Like in this particular patient, the whole mesorectal fascia is actually thickened. So whenever we see a circumferential thickening like this, it is more about a post-RT change. In terms of perirectal stranding, generally it can be difficult to evaluate, and dark hypointensity in the stranding could represent actually fibrosis, particularly if the previous stranding showed intermediate signal intensity. So what is important is that we need to see the signal change post-treatment. So if it was hyper or intermediate signal intensity, post-treatment it should be hypointense. So this was a patient in which this actually, if you would see, this was still hyperintense or an intermediate signal intensity, and now it has actually become hypo. So this was actually proved to be a dysplastic reaction. Where diffusion is important is that whenever it is a dark hypointense tissue extending into the mesorectal fat, it could be a fibrosis or a small residual tumor also. And however, whenever we see an intermediate signal, we should be careful in terms of is there a residual tumor, but we obviously cannot rule out an inflammatory response also. So that is where the diffusion weighted images come in handy. In terms of definite response assessment, this is the histopathological regression grade, and this is the MRI tumor regression grade, where whenever there's a complete radiological response, there is no evidence of tumor as per the criteria already listed. In terms of good response, it is a more than 75% fibrosis, moderate response more than 50%, slight less than 50, and no response where no post-treatment changes are seen. The post-treatment Y prefix is added for classification of after neoadjuvant chemo RT, and MRI has been shown to be useful in differentiating between YP T0 to T2 tumors from YP T3 tumors. Again, as I told you initially also, from T0 to T2, MRI is not very sensitive. It actually is that for that endorectal ultrasound is better than MRI. However, MRI is useful for the mesorectal spread and to differentiate between T3 tumors and advanced tumors. As at pre-treatment staging, differentiation among lower stage is again limited. And after CTRT, improvement of extramural vascular invasion. So whenever in the previous cases, if you would have seen the how the vein was dilated, so these are the ones, these tumors can completely regress, and EMVI can completely disappear post-treatment. So this is, I've shown you how we know that non-mucinous tumors may show response in the form of mucinous degeneration. So normally this would actually become hyperintense. So if you would see, so this is the tumor that was pre-treatment, and this is post-treatment. Size has shrunken. And however, if you would see pre-treatment, it was hypo, and now post-treatment, it has become hyperintense. So this can be actually due to post-treatment response in a non-mucinous tumor. However, mucinous tumors may respond by disappearance of the previous intermediate signal, which actually signifies. Uh, However, if there's a improved, if the signal persists, then that signifies that the response is not there adequately. So regression in the size of the tumor, we measure by measuring the craniocaudal extent. Like in this particular tumor, this was the extent initially, and post-treatment, how it has regressed. And however, there is no consensus on using tumor volumetry because it requires a lot of calculated, very complex calculations and dedicated software. In terms of regression of CRM status, so if there's a well-defined fat plane that was previously absent, if you would see on this image, there was no definite fat plane previously, and now there's a well-defined fat plane. So this would actually represent a response to the post-treatment imaging. Uh, Regression in sphincter involvement, where this was a pre-treatment imaging, how the tumor was actually invading into the sphincters, and post-treatment, this is all response, and this is how it has regressed. However, we need to know that the tumor may retract significantly in size, but the fibrotic reactions can sometimes cause confusion in such patients as well. Regression in nodal size is another important factor. This is the lymph node post pre-treatment, and this is the lymph node post-treatment. So also, if you would see that this was previously high signal intensity, it has again gone on low signal intensity. That's another reason. That's another factor for constituting the tumor response evaluation. Other sets of images. This highlights the role of diffusion weighted imaging. So this is the pre-treatment imaging. You would see high diffusion restriction on these images, and post-treatment, not only the size have regressed, but even the diffusion the diffusion restriction has gone in these lymph nodes and the lesion as well. In terms of the contrast enhanced imaging, there's a factor transfer constant called K-trans that actually denotes the rate of contrast material transfer from the blood to the extracellular space and relates to microvascular blood flow, vessel wall permeability, and vessel density. So this is actually the most widely used parameter for purpose of a response assessment. And there are good papers that talk about this. K-trans has been shown to correlate with tumor vascular endothelial growth factor and tumor aggressiveness. Higher pre-treatment tumor K-trans has been shown to be a useful marker in predicting the response to CT-RT. So there are papers that talk about this, that talk about that addition of dynamic contrast enhanced MRI increases specificity and the postoperative value, however, which was not statistically significant, but it does add to help in patients in which there is a confusion. So there's one such patient that talk about the post contrast, the K-trans measurement. And if you would see in this particular patient, it is a significant response, not only visibly. However, if you would do calculations to measure the K-trans in this particular patient, you would see that some reddish areas are still seen. So this is something, a viable tumor is still seen, and you would need to go ahead and then plan accordingly. I talked about diffusion. ADC values obtained at diffusion weighted images are reflective of tumor cellularity, with lower ADC value associated with higher tumor cellularity. So you should always compare the pre-treatment ADC values with the post-treatment ADC values, because that is something that would suggest the predictive response of tumor response. So if you would see that in this particular patient, so this is the pre-treatment imaging, and post-treatment, there is an increase in ADC post-adjuvant, and low to intermediate perfusion corresponds to plateau type curve, which is consistent with a non-viable tumor. If this would have been reddish, that means there would be a rapid inflow and rapid washout that would have suggested a viable amount of tumor in this particular patient. So this is a patient where it really helps that this is the pre-treatment imaging, this is the post-treatment imaging. So if you would see, the size hasn't decreased much on the T2 varied images. However, in terms of diffusion restriction on the ADC map, it was previously black and now it's white. So that signifies a good response in on ADC maps, even though the size had not reduced. But this is telling me that this patient had responded to the neoadjuvant CT-RT. In terms of post-operating imaging, it varies from depending upon what the surgery has been done, whether it's a LAR or the APR. And in terms of the main role of the radiologist is to look at the any post-surgical appearance in terms of whether there's any soft tissue or fluid collection, look at the suture line, the wall thickening at the anastomosis. And there's a larger pre-sacral space now that we need to be sure of. And we should rule out anastomotic leaks and recurrent tumors. In terms of APRs, again, there's a significant alteration in the abdominal pelvic anatomy, and we need to assess all the pelvic structures, the bladder, seminal vesicle, the small bowel, and accordingly, we need to get back. So this slide actually talks about the post-operative complications. So we see a pre-sacral correction in this particular patient. So this has got a fistula now in this patient, and again ascites and a disease recurrence in this particular patient. So these are the findings that we need to look for. And again, for post-operative evaluation, CT is more better and handy than an MRI examination. Some recent advances, we know artificial intelligence is coming up big way in radiology, and now we have texture analysis that talk about better tumor assessment, and not only that, post-treatment response also, which is pretty accurate. And there are numerous papers that talk about this, where we just take out the values of textures from the tumors, and accordingly we can plot it on a graph. And post treatment, again, this texture will show a good response or in terms of no response. So this will actually be very accurate in terms of predicting the response and early assessment of such patients. This is my final slide. This actually sums up the whole radiological evaluation in terms of CA rectum. So basically, in terms of radiological evaluation, we have to talk about the craniocaudal direction, so that the radiologist, so what is most important is that the whole all the people, whether the surgeon, the medical oncologist, or the radiation oncologist, should be on the same page as the radiologist in the hospital. And this is what we have done in our hospital. So we have a structured reporting format, and all of us know what the surgeon expects out of us. What surgeon would also know what I mean by reporting what I have done. So in terms of the craniocaudal direction, the circumferential plane, by which I mean the O clock position, the length of the tumor, the relationship to the anterior peritoneal reflection, the distance from the anorectal junction and the anal verge, whether it's a mucinous or a non-mucinous tumor, the T staging and the CRM status, that is important. When the distance is less than 1 millimeter from mesorectal fascia, it is a positive CRM. And when the distance is 1 to 2 millimeters, it is a threatened CRM. We should also assess the sphincter complex status for low rectal tumors for treatment and surgical planning. In terms of primary staging, this is a mnemonic, rectal, evaluate the MRI sequence, shape appearance, T-stage appearance of the tumor, and location of the tumor. And for restaging, CRM status, always analyze the prior MR images. That is very important for evaluating post-treatment response. What is the end stage? If it is a low rectal tumor, talk about the sphincter complex. What's the EMVI status, and how the tumor has regressed. So this is all about imaging evaluation in CA rectum, and how we go about evaluation prior to the disease and then post-treatment also. Thank you.